these succeeding topics, we'll be discussing the disturbances in digestion. We will be focused on gastrointestinal bleeding, then you will have gastritis and peptic ulcer disease. Let's start with gastrointestinal bleeding. Your gastrointestinal bleeding is considered to be an emergency because if it will not be addressed right away, it can cost the life of your patient. If you would look at the picture, these are the images of your stomach on your left and then your esophagus on the right. These are the normal endoscopic images of your organs. Now, to compare that to somebody who has gastritis, okay, or somebody who is at risk, for gastrointestinal bleeding, you are looking at the three abnormalities on your slides right now. Okay, so you have your peptic ulcer disease, which is shown on your right. The one on your left is indicative of gastritis on the upper part. Okay, this shows gastritis. And then the one below shows your esophageal varices. So these three conditions are the three major causes of bleeding among our patients. So peptic ulcer disease, gastritis, and then esophageal varices. So what are we watching out for in gastrointestinal bleeding? Your gastrointestinal bleeding is can be massive, and can occur because of hematologic disorders. Okay, for example, decreased platelet. Recall conditions such as your dengue hemorrhagic fever, or recall conditions wherein your patient has thrombocytopenia. This decrease in your platelet can lead to the bleeding of your stomach. Remember, the stomach is rich in blood vessels, and at the same time, the stomach contains acid. Whenever there will be problems on the clotting capability of the blood. There is high risk for massive gastrointestinal bleeding. Okay? Now, for the lower gastrointestinal bleeding, we usually refer to that as LGIB. Okay, that is commonly secondary to hemorrhoids and then colon polyp or colon abnormalities or neoplasms. Okay, we usually refer to upper bleeding also as UGIB. So if you see diagnoses such as UGIB and LGIB, that would stand to upper and lower gastrointestinal bleeding respectively. Now, symptoms. The symptoms could be the presence of blood in your vomitus, hematemesis, or the presence of blood in your stool, hematochezia. There may be melena or black tarry stools, especially if we're talking about upper gastrointestinal bleeding. Your abdominal pain, although among the first signs of your gastrointestinal bleeding, is considered to be a vague sign. Okay, abdominal pain is indicative of a lot of disorders. That's why one thing that you need to rule out when your patient is having abdominal pain is to rule out for the presence of bleeding. Don't just assume that your patient is having a simple pain that could be addressed by simple medications, because that could already be indicative of bleeding. Later on, okay, usually when the patient's bleeding progresses, they could not complain of pain anymore because the patient may be already unconscious because of too much blood loss. Now, other signs and symptoms are related to your anemia or your blood loss. Take note, this could result to hemorrhagic shock, hypovolemic shock. So anemia is one of our problems. The patient will have easy fatigability. With usual activities, your patient would complain of fatigue. Also, your patient would complain of weakness, okay, because of the lack of oxygen, because of the lack of the red blood cells that carries oxygen to the vital organs of the body. Your patient will also manifest with pale skin, and due to the act of the lungs to compensate for the decrease of the oxygen, there will be tachypnea initially and then shortness of breathing later on. Diagnostic test. If we're talking about blood or examination of presence of blood in the stool, we'll be doing your digital rectal examination. If we are ruling out for upper gastrointestinal bleeding, for example, bleeding from your esophagus or bleeding from your stomach and then the duodenum, we'll be doing your endoscopy. If you can recall, we have the term EGD or your esophago-gastroduodenoscopy. Then if we're exploring bleeding of the lower gastrointestinal tract, we'll be doing your colonoscopy. So kindly review the preparation for these examinations prior to conduct. Then laboratory test, CBC. If your patient is bleeding, whether it is overt or covert, you can see it or you cannot, the CBC will show you if the RBC is decreased. Okay, the CBC will also show you if the hemoglobin and hematocrit are decreased. This is indicative that your patient is losing volumes of blood. Then platelet. Again, as mentioned, thrombocytopenia increases the risk for bleeding. You also have your clotting time and your bleeding time. When your clotting time and your bleeding time is increased, you would suspect that your patient is also at increased risk for bleeding. So as your prothrombin time and your activated partial thromboplastin time. Another laboratory test that would be important is the blood type of your patient. Because if your patient is having gastrointestinal bleeding, the best intervention that we can do for them is to stop the bleeding through surgery, of course, with the physician, and then administration of your fresh whole blood. In this case, class, the usual blood product being administered is your fresh whole blood because your patient is also losing whole blood, meaning not only the RBC but also the plasma and other components of the blood. Hence, fresh whole blood is the one that is being administered to our patient. Management. Our management here is geared towards early identification of your hypovolemic and your hemorrhagic shock. Because if hypovolemic and hemorrhagic shock would progress, that may be fatal to the life of your patient. So early signs of your hypovolemic shock would include decrease of your blood pressure. There may be a thready pulse. The pulse may be increased, but the pulse is weak and thready. And then your patient has the tendency to become hypothermic. So, do patient needs to be hospitalized? Obviously, your patient needs to be hospitalized. So, vital signs are again monitored for hypotension, and then initially your weak, thready pulse, rapid pulse, but later on it will become bradycardic once the compensatory mechanisms are failing. Fluids. When I talk about fluids, we're usually talking about isotonic solutions here because your patient is losing fresh whole blood. So that would include the administration of your plain NSS bolus and then the administration of your plain LR or lactated ringers solution. There may be volume expanders that will be administered to your patients. The purpose of the volume expanders is to expand your plasma. And then blood transfusions. When I say blood transfusions, because there are a lot of blood that is expected to be administered. In severe cases, we may administer up to 4 to 6 units of blood for our patients' vital signs to normalize or for our patients to regain homeostasis. Because again, gastrointestinal bleeding seems to be fatal due to the rich blood supply to our GI tract. And again, the blood of choice or the blood product of choice is your fresh whole blood. But prior to administration of your fresh whole blood, make sure that you have undergone the blood typing and then cross-matching. Okay, we only transfuse compatible blood to our patient. If the patient's blood type is not available, our universal blood type could be used. And what is the universal blood type? That would be blood type O. Is it O positive or O negative? That's a question that you need to answer. Immediate interventions would include your cardiac stabilization because we're talking about the cardiovascular system of the patient, which has a tendency for collapse due to the lack of blood volume. Second, identify the source. Okay, identifying the source would treat the actual problem. So we need to know, is it from the esophagus? Is it from the stomach? Is it from the lower GI? And then stop the bleeding. Stopping the bleeding may actually entail you to insert an NGT tube, a special kind of nasogastric tube, or may entail us to bring the patient to the operating room for an immediate and stat surgery. And then, of course, your psychosocial support. Because if there is anxiety, anxiety increases the blood or the oxygen demand of the body, which is not helpful if your patient's blood is being depleted. Then, for upper GI bleeding, as I have mentioned, nasogastric tube, and then you have your gastric lavage. So your gastric lavage is commonly referred to as your stomach pumping or your gastric irrigation. So what happens in gastric lavage is that okay, a cold fluid is usually administered. We usually use saline. Okay, a frozen or cold saline is being administered to the stomach of the patient via the NGT and then irrigated out. The purpose of that is to facilitate clotting in the stomach because of the cold temperature and to evacuate the blood and evacuate the clot. Then we have a special kind of NGT that is being used. One of that kind is your Singstaken-Blakemore tube, and then another is your Minnesota tube. So again, you have your Singstaken-Blakemore tube and then your Minnesota tube. The purpose of this is to apply pressure to the lower esophagus. So these are tubes inserted and dilated to control bleeding, to tamponade for the bleeding of esophageal varices, following the principle that whenever there is bleeding, we apply pressure to the site of bleeding. Now, if you would look at the tube, there is a gastric balloon port, there is an esophageal balloon port, okay, there is a gastric aspiration port, and this is where you can get the gastric contents if ever needed. So whenever the tube is inserted inside the patient's body, it will be inserted like that, and then the tubes will be inflated. So there is an esophageal balloon inflated at the lower or the distal end of your esophagus if the bleeding is there. A gastric balloon is also inflated if there is bleeding there. Okay, and the purpose also of the gastric balloon is to ensure the location or to take hold of the location of your NGT, okay, or your tubings here. So the diagram on the right may be able to show you the same tubes, and then as you can see, it is inflated on the distal end of the esophagus going towards the stomach. Now, if ever, okay, this tube is prescribed to your patient, you need to maintain elevation of the bed to enhance lung expansion and reduce portal blood flow, permitting effective esophagogastric balloon tamponade. So again, we refer to that one as tamponade. We're applying pressure to the bleeding site. However, there is a risk for this procedure. Okay, there is a possibility for this tube to be dislodged upward. Okay, so when I say the tube is dislodged upward, this balloon, okay, this balloon may go up and then cover the airway of your patient. Okay, leading to poor oxygenation towards your patient, ineffective airway clearance. In that case, we need to stand by scissors at the bedside. What will be the purpose of your scissors at the bedside? So you need to monitor for respiratory distress whenever you enter the patient's room and you have detected that there is respiratory distress. Right there and then, cut the tube. Okay, we cut the tube on this part. What is the purpose? We need to cut the tube to release the pressure, because if your patient is experiencing respiratory distress, we suspect that the tube is already dislodged to the respiratory tract. So as an emergency procedure, you do not use your syringes to withdraw the contents of your tube. Instead, you need to cut the tube as an emergency procedure to save the life of your patient. So again, the two kinds are your Singstaken Blakemore tube and then your Minnesota tube. Then the possible nursing diagnosis. It's risk for bleeding if we're talking to related to dengue fever, related to thrombocytopenia. So risk for bleeding if bleeding did not occur yet. Then we have deficient fluid volume related to blood loss, decreased cardiac output due to decreased circulating blood or decreased RBC, and even ineffective tissue perfusion. We're talking here not only of your peripheral tissue perfusion, but also your gastrointestinal tissue perfusion because of blood loss. So that is an overview of your gastrointestinal bleeding, which is a common complication of the succeeding diseases that we will be discussing. Okay, so coming soon on our next topic is gastritis. Thank you very much for your kind attention.